All right, good morning. I hope you all had a good weekend. This morning we have Dr. Desai, who is the founder and CEO of RestorePDX out in Southwest Portland, Beaverton area. He's going to talk to us about interventional pain in sports medicine with imaging and interpretation review in the first hour. In the second hour, we're going to cover all topics related to restorative medicine injections. So without further ado, I'll hand it over. Thank you so much.
Good morning, everybody. Thanks for showing up so early. I'll try to speak well for 2 hours. If I start getting tired, just throw something at me. But we'll take a little break in the middle. Just wanted to first thank my staff at Restore. I always forget to do that, so I'm going to start off with that. We have a wonderful group of physicians and practitioners that are helping build this new practice model, and we'll talk a little bit about that as we go. But just want to give them a shout out, and we'll start. Okay. This is my family, so wife, dog, 4 kids. So they were really excited about my show and tell this morning. So last night they said, "Dad, I have a really good show and tell," and that's kind of what it is. It's we'll talk about some of the science and other things like that, but basically I'm going to tell you a little bit of my experience. A lot of this stuff is somewhat anecdotal. Now we're going to look at some imaging and talk about interventional pain. There was a lot to bring together, and there's a lot more to discuss, but what I wanted to start off with was something that we see a lot of, that you're going to see a lot of in your clinical practices, pretty much any specialty that you get into, and that's going to be low back and spine pain. So we'll focus a little bit on that, but we'll talk about the importance of some of the adjunctive things around dealing with pain in sports medicine. What can I impart on you today? And my hope is that we'll learn a little bit of science. The other thing that we'll want to do, and we may want to turn the lights down at a certain point, is do what you believe in. And so you guys are, it's exciting to see young, enthusiastic physicians of the future that are coming into this, into this world, and to give you a little bit of insight and inspiration into do the things that you want to do. Obviously, there's a system out there. You're already a little bit adventurous in your spirit to do naturopathic medicine, and continue that, believe in what you're doing. Dare to create your own path. So something that is out there, you're going to have all of this education and people coming up and telling you all of this dictum and these facts and how to practice medicine, and obviously that's going to build your foundation, but remember to create your own path. If you do what's truly making you happy and doing the things that affect your patients, you'll be happy, because there's going to be tough times. There's going to be times you're working really hard, too many hours, not enough pay, and if it's something that you don't believe in or not happy with, it's going to affect your life and everybody around you. So do those things. Remember the safety of your patients. That's paramount. So all the things that you're doing, make as sure as you can that you're keeping them safe. Some of these things are, especially in my line and my practice, we have branched out in some of the regenerative medicine techniques, and we've gotten some flack from the community. My training is in allopathic medicine. I'm an MD radiologist, so one of the most kind of black and white fields that you can get into. And we've pushed those boundaries, and we've gotten some flack for that. But the tenets that we always keep are to make sure that your patient's safety is paramount, and the first thing that you deliver is that. Remember, do no harm. Continue to push yourself. Gain that knowledge. Go to courses, CME, use PubMed. Try to keep if they have a proxy server, some access to literature. When you get out into the field, it's something that you need to always look back into. And if you have access to journal articles, you have access to those things, whatever, if there's a local library or something with your medical institution, continue to do that. Also reach back out to NCNM when you're out in the community to be a teacher, to allow, to further that information that you're gleaning to the next generation. Use your colleagues, journal clubs, those types of things, and try to get involved in the research. There's a lot of neat things out there with industry, with private individuals, and even within the practice that you're performing with. Try to keep information. A lot of that information can be looked at retrospectively. You're going to start to see patterns of thought. You're going to see patterns of theory and treatment, and you want to keep those that information. So EMR, those things are helpful with that. But even if you don't have that, make a system. Use an Excel file. Use Word to keep that information. And then do the best to treat your patients. Use your humanity, humility, and love. I see this too often, especially in the allopathic world, where some of these things are lost. Treat other patients like your family. Treat them with humility. Admit you're wrong. There are times when you don't know the answer, and instead of brushing them off, just tell them. And I don't know the answer. I'll try to look this up. I may not have the best information. And then use your resources. Don't be afraid to say, I may not be the best person for this, but I know someone else that can help you. And allow them to get that information. And then finally, just treat them with love, and all this other stuff will happen. All right. So one of the things I want to do, it's 7:35 in the morning. What I'd like to do is have everybody here who's ever had a pain issue, low back pain, that may not be something that has persisted or you've sought treatment for, but anybody that's had low back pain or back pain in the past 2 years, please stand up. All right, that's scary. You guys are so young. Start stretching. No, that's go ahead and sit back down. This will get some blood flowing. Good. So that's low back pain. So probably 70%, 67% of you stood up. How about any of you that have had joint pain? Shoulder, knee, ankle, wrist. Please stand up again. We'll get the bone. It's the same people. Yeah, exactly. Yeah. So it is. I think in part we're such an active society, and in Portland here even more so. It's wonderful for your musculature, heart, lungs, those types of things, but it can wear down those joints. You have injuries, and some of these things can become chronic. The lifetime prevalence of back pain in the U.S. is between 60 and 90%. 14% of people will experience back pain episodes of up to 2 weeks or longer. And it's the second leading cause of absenteeism from work, causing 25% of the missed days of work. Can have a large effect on the disability and chronic disability prevalence. This is some information, and I've tried not to show you too many charts, but it was just interesting. This is data from 2012, and this is age-adjusted, self-reported medical diagnoses or conditions. And it's a little bit hard to read, but it's musculoskeletal, emotional, circulatory, sleep, respiratory, migraines, diabetes, cancer, cognitive disorders. And you can see here, this is per 100 persons. Over 50% are reporting that they're having, and we can see that in this classroom, are reporting significant musculoskeletal issues. So obviously this is a huge part of our societal drain and societal effect on medicine. This is prevalence of self-reported MSK diseases. So these are the different diseases: chronic joint pain, arthritis, neck pain, low back pain, and low back pain spreading below the knee, or radicular type symptoms. And you can see here what I thought was interesting. Obviously there's per 100 patients, or per 100 persons, a lot of folks that are affected. But there's age distribution: 18 to 44, 45 to 64, 65 to 74, and 75 and over. One of the things that stays relatively constant from a 24 to a high of 32 is low back pain. And so we're seeing that you're a very young population here, and we're seeing that you can be quite affected by this. This is a comparison of musculoskeletal, circulatory, and respiratory diseases, and spread out over the different age groups. And you can see again, the MSK starts at 42 over 100 and increases, and only after 75 years of age do we see the circulation or circulatory issues overtaking musculoskeletal problems. And so this is patients over 18 years of age in different areas of musculoskeletal joint injury or self-diagnosed pain. You can see that knee, hip, and shoulder dominate. Okay, and that's what we most often see in the clinic. And this is not just arthritis. This is soft tissue injury, ligament sprains, strains that sometimes start out acute and then become chronic. And here are the effects societally and the gross domestic product of the U.S. And you can see from 96 to 2011, it's steadily increasing. And this is only going up with the baby boomers and the effect of increased utilization of surgeries, total knees, total hips, and even arthroscopies. This is also indicative of the societal costs of medicine, so pain medicines, anti-inflammatories, the celecoxibs, as well as opiates. So this is a very big issue. Those 4 girls that I showed you in the beginning, they're going to grow up in this country, and I'd like this country to be a good one. And the societal costs of medicine definitely pose a challenge. And so what do we do? This is $850 billion just in musculoskeletal healthcare. This is direct costs as well as lost wages, lost time at work. So what we have tried to create and what we're creating at RestorePDX, but also in this community, is a more holistic and interdisciplinary approach. We're trying to be cost conscious, and this is what I'm going to harp on you a little bit, is this diagnostic-based medicine. And I think too often that we're treating symptomatology and we're not digging deep and finding out what's actually happening to this patient. Why are they having this disease process? And then what I'm very into and excited about are the regenerative medicine types of therapies, and we'll talk about that. So fancy word, interventional pain management, sports medicine. What exactly is this? So it's basically image-guided diagnosis and therapy of commonly encountered pain syndromes. And this can be chronic pain, this can be pain secondary to athletics, in the sports medicine arena, and really focused around spine, joints, and soft tissues. Where do we fit? So this slide's a little bit hard to see, but you have this painful patient right upper corner of the circle, and they often seek conservative therapies. If their issue lasts long enough, they're bothered enough, it's affecting their lifestyle, they're going to seek therapy. And they're going to seek that through their primary care physicians. They may go to chiropractic, massage therapy, acupuncture, physical therapy, occupational therapy. And most of those patients are going to do very well with those conservative therapies. Their problem's going to be identified. It may be a self-limited issue, and they're going to come out of this circle or continuum. It's those patients that have failure or limited success that we have kind of intercepted or started to see. And basically our goal is to, at this point, they've tried these conservative measures, and this may be for weeks or months, and we're trying to find out why they're having these issues. Okay? And so we utilize this multidisciplinary approach. So we're seeing the patients, doing as good a physical examination, neurologic examination as possible, taking a good history, and then if they need the imaging, we're going a step further and trying to identify the injury. If it's something that can be treated with minimally invasive means, that's what we're doing. If not, we're at least triaging them to the right clinician, the right service to get that fixed. And so if we have failure or limited success, then they may move on to a surgical consultation. They may move on to a psychological consultation, so depending on what issue they're dealing with. So a patient comes into your office, seeks care for a particular painful region. What are we looking for? And I think this gets lost, especially with what I've seen with residents or newer physicians, or even in the primary care setting, because you're handling so many different things, is we're not going after this. Okay, and this is the diagnosis. I think it's really important. Oftentimes we're looking at the symptoms, and we're simply treating the symptoms. They have this issue. They have shoulder pain. What are we going to do? Okay, we'll prescribe them for some physical therapy. I'm going to give you some anti-inflammatories, maybe some muscle relaxers, and we'll see you in 6 weeks. All right? Shoulder pain diagnosis. Has that been worked up? Has the proper physical examination been done? Why are they having the shoulder pain? Is it coming from their neck? Is it adhesive capsulitis? I mean, there are true diagnoses that need to be sought out. And the same thing exists for low back pain. I think for low back pain, it's even more difficult because there's so many mimics. Okay, and so then we're going to talk about some of those things. And just to reemphasize, if anybody has any questions as things come up, please just stop me. I'll reiterate the question, so we'll have it recorded, and then I can try to make an intelligent answer. So the right diagnosis, and this is important too. How do we get to the right diagnosis? So these are all important things, and I think are lost, unfortunately, because we see a lot of these referrals. We see a lot of secondary referrals come in. Sometimes we're the last resort. But patient history. So really dive into that. When did the pain start? Why did it start? How long has it been going on? What are exacerbating factors? Has this been treated in the past and gotten better? Has it been treated in the past and not gotten better? All of that's going to give you information. And you have to go into the old records. It's very difficult for patients to remember all the things, especially if it's been a chronic issue that have been done. So it's on your onus to call those facilities to try to get as many records as you can. That's going to guide you because they may have had, you may be thinking in a certain line of therapy, they may have had all those therapies already performed and failed. So you may need to start thinking of novel approaches, or we may be barking up the wrong tree, right, as far as their diagnosis. Physical exam is very important. And this is coming from a radiologist, right? So I'll give you a little bit of background for myself. When I started practicing 6 years ago, I came out of an interventional musculoskeletal radiology fellowship. we were sent patients to do procedures on. So the doctors would, from the clinic, they'd see somebody that was hurting, they'd send us a patient, we'd do an epidural, I'd consent them and send them back. Read all the imaging, MRI, CT, X-rays, those types of things. When I came out to private practice, started seeing the same type of thing. We were starting an interventional pain practice. Physicians, clinicians would send us patients, and I would be able to interact with them a little bit more in that setting, a small private practice. And they would come in and I would start talking to them about a certain issue. We were going to inject a facet joint for back pain. I'd look at the imaging and I'd talk to the patient, and they were having lancinating pain extending down the leg, numbness and tingling in the toes, and they wanted, they were coming in for a joint injection in the back. It wasn't really the right injection. So I'd talk to them, take time, examine them a little bit, and I'd call the physician or clinician and say, hey, can we move this to an epidural? I think it might be a little bit more effective. And they said, sure. So this started happening with some regularity, and I would keep calling, and then they got sick of me. So I said, please stop calling. Can you simply see the patient? We're just going to send them to you. And I went to my boss at the time and said, can I see a patient in clinic? I don't know how to exactly do that. Do we have to do this and that? And so we started actually seeing the patients. So they're like, yeah, you have an MD. So I thought, all right, let's see them. So we started working on that. One of the biggest things in my challenge the last 7 years, and I'm still working on this, is the physical examination. And it's a really important thing. And each year, I seem to add something to that repertoire. Something becomes more solidified in my mind. And it takes a long time. I think in medicine in general, we have lost this art of physical examination. And especially, I'll speak a little bit for the allopathic field, not as much for you guys, because I'm not sure about your training, but I see it in our field, is that we have really lost that art. We rely so much upon imaging. We rely so much upon the other arts that we have, labs, diagnostics, that sometimes we forget to put our hands on the patients. We have a new PA that's joined us from the neurosurgical world, and I have a chip on my shoulder because I'm a radiologist, so I try to make my physical exam as good as I can, that she was very surprised at our level of acuity for our physical examination. And so over the last couple of years, we've started to use a lot more tests for SI joints. Imaging has changed. We'll talk about that. And we've seen a lot more correct diagnostics, correct diagnoses, and better therapeutics. Imaging. I think I'm very biased, obviously radiology training, but the imaging nowadays is quite fascinating and very elucidating. There are 3 Tesla MRIs, or very high field strength MRIs, as well as musculoskeletal ultrasound that's giving us a lot of information. The interesting thing that I've noticed in the past is that there is a large disconnect between the imaging and the clinicians. And so that's something that our practice, and we're going to develop more and more of these type of practitioners, is the connection between the imaging and the clinical side. There are times when most of the musculoskeletal radiologists, most of neuroradiologists in the country are reading for surgical diagnoses. Right? They're being sent cases by neurosurgeons, by orthopedic surgeons, even by pain medicine physicians, but they're looking for surgical outcomes. They're looking for disc herniations, they're looking for things that are broken or fractured and need fixing. What they're not looking for is sources of pain. And that's been something that I've noticed over and over, that we see patients, the diagnosis is screaming at you on the MRI, and it has not been discussed or touched upon at all. And so that leaves the clinician in a really bad spot, because the clinician, they don't know how to read the MRI. They don't have that training. They come in, they're referencing that imaging report. So they go see all these things. Okay, disc herniation C5-6, and that's what the source of the pain is. Where they may have a raging inflammatory arthropathy, they may have ankylosing spondylitis, they may have something else that's actually driving their pain syndrome, but this is never discussed on the imaging, and it's there. So that's one of the things and that's the onus on the radiology side. And we've been discussing this. We're publishing some papers and abstracts as well with Dr. Wright, one of your colleagues, and talking about the importance of this. Diagnostic and potentially therapeutic injections. So this is something that we do when we have the information. We know that we're looking at a source. We've done all these other things. And sometimes, especially with the aged spine, somebody that comes in and sometimes age is 35, sometimes it's 85. But that person comes in, they have multiple issues. They have disc disease at multiple levels. They have multiple level arthritis, SI joint issues, soft tissue issues. Where do we start? Again, we use all these things, and sometimes we need these injections to help us guide where it's coming from. And so these are diagnostic, and I always cross my fingers, potentially therapeutic injections. And so we're trying to figure out what the source is. Oftentimes I'll use corticosteroid, because right now in the insurance world, those types of injections are paid for. Unfortunately, the regenerative medicines currently are a cash pay item. So we want to find out, if we're going to use those regenerative medicine techniques, spend the patient's hard-earned money, let's make sure it's in the right spot. Okay, we're going to have the best effect, they'll be happy. And then follow-up. So just doing an injection and sending them on their way is not enough. Now, we do a pretty rigorous follow-up. We have pain diaries that the patients take home. They fill those out. So if we're doing a particular injection, we want to see what's happening. What gets better? What doesn't get better? What are the side effects? What are the issues? That can help glean things. Because sometimes, maybe there's 3 or 4 bad actors in the spine that are contributing, and maybe all those issues need to be addressed. So what does the wrong diagnosis do? And this is the sad part. Prolongs the pain and suffering, improper injections or therapy, and more unfortunately, improper surgeries, which we see all the time. A very gross issue that we see not uncommonly, it happens a few times a year, is somebody getting a spinal fusion or vice versa, a hip replacement, and it was the other issue that was causing the pain. Okay? And then you go back in their chart and nobody even did an x-ray of the hip, or nobody evaluated the lumbar spine for any pathology. They came in, they talked about it seemed like a good story, we'll set you up for surgery, you failed this, that injection, and off they go. And they don't get any better. And now they may even have a new issue, right? So new issues or new problems that the patient didn't have before. They didn't have pain in that area, now they do, plus they have their old pain. Or the bad outcomes with infections and other things. And this leads to this narcotic use and overuse, and something that we don't believe in. We very sparingly use narcotics after regenerative medicine procedures. We don't use it as a chronic pain medicine for chronic pain. Why don't things work well? We talked about this. Lack of communication between providers. And this is not just between the imagers and the clinicians, but this is amongst the actual clinicians. So this is something that's very important. It is hard because, when we suffer from the same issue, you have a busy day of clinic, and you need to connect with someone to talk about, does this seem appropriate? Should we move this way, or do I need to send it back to you? You need to connect with the other clinicians. It's difficult, but try to make that happen. It's going to be really important for your patients. There's fundamental issues with fee-for-service, and this is changing over time, but we are incentivized to do more procedures. We're incentivized to do things. So if you are a surgeon, or if you're an injectionist, the same way, people come in, that's what you're incentivized to do. You need to keep the doors open, and you need to do these therapies. And so what we're trying to do is move towards outcomes-based or global type of payments. And I think that's important. So if we can show that this type of therapy is more effective, or we're getting people better, faster, for cheaper, it's going to be much more effective, and that's going to help society in general. And then we talked about this disconnect, and we're both responsible. So we're trying to do our part for this. So here's a very biased opinion, but finding a trusted musculoskeletal radiologist, if you get into the sports medicine or interventional pain field, which there'll be plenty of work to do, find a good radiologist to work with. It's going to help. You don't need them all the time, but when you have those difficult cases or you want to find out what type of imaging you need to do, it's always helpful. This is a completely and utterly biased opinion, but shockingly not all MRIs are read correctly. They're not performed correctly with the proper imaging tools, and they're not diagnosed or read correctly. The other thing that, with this, I'll take the blame as well, even within our own practice, there are times when I have the referring clinician, if our nurse practitioner, Jeff Grimm, if he orders something, or we have Dr. Bennett, she's a DO, or Dr. Anderson, who used to be with us, they would order studies. And I would try to read their chart notes before I dictate something to find out what they're looking for. But there are times when their hands found something on the physical examination that they would come in and talk to me about, and I had missed things. And I said, well, you're right. There is a little bit of inflammation in that joint. I think that's probably where it's coming from. I'll dictate an addendum. Okay, so that's okay. But having that interaction with your radiologist is very helpful. And again, remember that out in the community, wherever you practice, you guys may be all over the country, remember that there is a bent for your radiologist to read for surgical diagnoses. So start maybe looking at those images, taking a look, and we'll start that process today. So back pain, lower extremity pain. What are you looking for when that patient comes in? And I try to break it down into these main blocks. Okay? Mechanical. Is there a mechanical disruption? Is there a disc herniation? Is there scoliosis? Is there some kind of instability? Do they have a pars interarticularis defect or spondylolisthesis? They have something structural that's wrong. Did they have a cam type impingement of the hip? Is there something else structurally that's affecting their pain and causing this? This can, and it's closely tied with inflammation, because they can have some mechanical disturbance, but usually, and it's not going to start to become painful unless there's a certain degree of inflammation. It may, still with mechanics, but there is oftentimes an inflammatory component. One of the things that's going to be very effective is high field strength imaging with fluid sensitive sequences. Sounds fancy, but basically we get to see inflammation. With the MRIs, you get to see where fluid is. You can, and I'll show you the images. So it's very sensitive in picking up areas of inflammation. So you can look at all the labs and different things and talk to the patient, push on them. But there are times, and sometimes I feel like MSK radiology and pain radiology is quite simple. All you do is a really good fluid sensitive sequence and then look for the bright spots, because that's where usually the inflammation is, and oftentimes that's where the pain is. Neuropathic pain. So this is something either a systemic issue with vitamin deficiencies, diabetic issues, and it can be from chronic compression or neuropathies. If a patient has had a spinal issue or stenosis for long enough, they're going to affect the dorsal root ganglion. They're going to affect the nerves. And these may be a chronic issue where it's a neuropathic pain. And you may not see anything on the imaging. You may see secondary signs of why something's happening, but you may not pick up why exactly they're having the pain. And oftentimes this is a rule out, where we have to use EMG, nerve conduction studies, and then just good physical examination, and there's some exclusion criteria as well. And then psychologic. And this is an important thing, and something that I'm working on personally, to try to understand this more and get patients the right resources. Probably one of the biggest things that's lacking currently in our practice is an in-house psychologist for sports and pain. But I think it's very important. And this plays a huge role. There's fear and avoidance behaviors that occur. There's a lot of other things that will affect the patient, that if this chronic pain has been going on, they're going to restrict their body's motion. They're going to create secondary effects that may not be there based on this. And so this is something to look at as well. And you have to talk to them about their family situation, the stresses that are upon their life. And we can see this with our patients, that we know they have some structural or inflammatory neuropathic issue. But when stress increases in their life, if they have a death in the family, if they have something else that's going on, their pain increases, and they're seeing us more often during that time. And to affect that, it's very important. You guys will have some of that training as well. But remember that side. All right, so the bony anatomy, we're going to go through this quickly. How much training do you guys have on spine anatomy by now? Pretty solid foundation? Yeah, okay. So I'm going to go through this pretty darn quickly, and then we'll get to some of the imaging. We may turn the lights down when the MRs come up. I don't want you to fall asleep, though. Anterior middle columns, all right, so here and here. So you have the vertebral bodies, anterior longitudinal ligament, and the posterior longitudinal ligament. In the posterior column are the facet joints, ligamentum flavum, and the posterior elements. So those are two areas where the anterior middle columns and the posterior columns, where we can derive axial low back pain. We also talk about the SI joints, and this has become more and more apparent in our practice that I was missing a lot of this. Through my training, I was missing a lot of this, and it's become something that's important to me and making sure that this is evaluated, because we are making wrong diagnoses. The SI joint, small range of motion, is where your spine meets your lower extremities. The S is for the sacrum, inverted triangle here, and then the ilium. Small range of motion. But it can become very painful and can mimic low back pain. One of the things that we have noticed this year, we treat a lot of SI joint disease, is that if somebody has a radicular symptomatology pattern, like a pinched nerve, don't rule out SI joint. It can present exactly the same way, and there may not be any disc pathology, nerve root impingement. But don't rule out that it's not coming from the sacroiliac joint. It's not just localized to the buttock or low back. The anterior portion of the joint is inferior and anterior, and it's a true synovial joint. And about 75% of the joint is posterior superior, is fibrous and ligamentous. And that's also does play an important role in the pain generation. So don't think the pain just comes from those from the joint. The neural anatomy, the central canal. So that's going to contain the epidural space and the thecal sac. It's bordered by the PLL and the disc, pedicles, and ligamentum flavum. So any of issues with any of these structures is going to cause issue with the central canal. And we'll talk about that later with a central stenosis. The epidural space, so it's from stem to stern, contains mostly fat and epidural veins. So it's an access site that you can put medicine in. And they put morphine and other medicines in a catheter for pregnancy. What we do is we're able to access this site and put in medicines such as anesthetic and corticosteroids, and now even platelet-rich plasma and other things to try to affect a change on those tissues of the nerves and the discs. Okay? The thecal sac contains the cord and the nerve roots. And remember, the cord ends approximately L1, and then you have the conus medullaris, right, that terminates, and then you have the filum terminale, which are the nerve roots that are dangling like a horse's tail, and those go down into lumbar and sacral levels. So now we talked about the central canal. And these are the neural foramen. This is a sagittal view, and you have the nerve root and the dorsal root ganglion coming out, 2 at each levels bilaterally, and there's quite a bit of pathology that occurs here. And so you can imagine everything's so close together. We call this kind of on the MRIs, you'll see a pork chop view. This fat will be bright, and you'll see the nerve root like a dot, kind of looks like a pork chop. And this is kind of a happy nerve root, right? It has lots of space. This is all soft fat, and has the small arteries and nerves, siniovertebral nerves adjacent to it. Over time with disc disease, you can see this disc. If it starts bulging, what's happening? This area is getting smaller. This is the facet joint. If that starts to get arthritic and hypertrophies, that area is getting smaller. So all those things occur, and if this disc is getting depressed or smaller, then this space in a craniocaudal or vertical dimension is also getting compressed. So all those things can cause compressive neuropathies, and we'll take a look. So we try to break down acute and chronic. Anything over a couple of months goes into the chronic phase for low back pain. And then we also try to do axial and radicular pain. So is it localized to the low back, localized to a certain region, or are they having pain that's shooting down the leg or the thigh? It doesn't have to go all the way in a certain pattern, and it can also skip. So if a patient comes in and they have some low back pain, plus or minus, and they have neuropathic type pain in the foot, don't exclude a causative agent from the spine. It's not always the case that it has to go all the way down. And so remember, any innervated structure in the spine can cause low back pain. All right, this is kind of a busy slide, so I'll go through this quickly. But acute, we talked about axial. So musculoskeletal, myofascial, muscular spasms, fracture, infection, neoplasm. So remember those kind of bad actors too, the things that are red flags, something that you don't want to miss. We've seen those cases as well. The radicular or radiating pain in an acute sense, so a herniated disc, infection, neoplasm. And then referred pain from organic issues if they have aortic issue, vascular issue, if they have a tumor in the liver, if they have retroperitoneal adenopathy. There's some other issues that can cause this axial low back pain. So look for the other things. Have they had a history of recent weight loss? Are they having any other issues? So all those things come into the history as well. And then chronic, again, you're looking at discogenic, joint-centered, so facet or SI joint issues, pars interarticularis pain. So those patients that come in 12 to 20, remember, look for those pars interarticularis defects or spondylolisthesis or spondylolysis. So it's very important. So they'll present younger patients, low back pain, and they can often have symptoms down into the legs as well. One example, we had a patient that came in, a 17-year-old female with severe calf pain upon any activity. She was an athlete, had been very active, and now even walking up a flight of stairs, severe leg pain. She'd been worked up in the community for a compartment syndrome. Really didn't fit the picture because she didn't have to take many steps to get the pain. Compartment syndrome is vascular engorgement in the calves, after high level activity, and there's poor drainage, and you have pain in the lower extremities and paresthesias. It didn't fit that picture. We even did an MR to look at the lower extremities. She did not complain of back pain, which is a difficult thing, and I think why it took so long for us to diagnose this. But after a while, we started talking and kind of doing more and more physical examination, just ruling out other causes. We had to look at your back. There's just nothing else that seems to be causing this. Was unrelenting. So we scanned her back, and she had bilateral pars defects, and there was really no slippage, and there was no nerve compromise, but the facets or the pars defects were edematous. There was inflammation. We treated her with bilateral epidural injections just to see if this pain would go away, and she had over a year of relief with those injections. And so even just the inflammatory component of those pars defects were causing that. So bracing, conservative management, and activity modification were prescribed for her, and she's doing better, but she's still dealing with some of those issues. Okay. We talk about radicular or radiating pain, so nerve root compression, neoplasm, and spinal stenosis, so neurogenic claudication or radiculopathy. Okay. And so axial low back pain mediated by the siniovertebral nerve. So this is a small branch. So here's an axial view of the spine, vertebral body, central cord, and there's the nerve root that's coming out. It sends off posterior division and anterior division, The anterior division sends the sinuvertebral nerve that feeds the disc and the soft tissues around the disc in the epidural space. So this is what transmits discogenic pain. So people talk about disc pain or disc issues, and now we're going to see more and more of this. That we're starting to use platelet-rich plasma and stem cells for regenerative therapies for the disc to try to heal them and reverse the course of injury. But this is the nerve that mediates the pain for that. So you can see how close everything is here. This is the spinal nerve, and this is the posterior division of the spinal nerve, and that feeds the facet joint and the deep musculature of the spine, so the multifidi. So this is the medial branch, and you'll hear a little bit about in pain medicine where you can burn this with radiofrequency ablation. So if you have arthritis in the back and it's unrelenting, it's not being helped, there's not a lot of surgeries, other things that help currently in our allopathic scheme. And what they do is they go into this nerve, we know where this lives, and you can burn it with radiofrequency heat. And that can basically disengage the nerve or stun the nerve, it doesn't kill it, for anywhere from 6 months to 2 to 3 years. And that's been used as a fairly effective therapy for facet arthropathy. The concerning thing is, what else does this feed? Right? This medial branch comes off here. It's getting those deep multifidi. So if somebody comes in and they're 35 years old and they have low back pain and it's facetogenic and they have inflammation, and you do a cortisone injection, they feel better. And then the next step is, but it doesn't work forever. And you don't want to keep dosing them with cortisone. What they can do, the next step in the standard model, is to do these radiofrequency ablations. Now, you're helping their pain for a bit, but what else are you doing? You're denervating this muscle. And what we're seeing on follow-up MRIs is early edema within the muscles, and then over time they're starting to get fatty infiltration and atrophy. So now what's the effect of this is destabilization of a young spine. Okay? They're guaranteeing them surgeries in the future. Okay? So that's where we have to be thoughtful about what we're doing. It's not always the best situation. Now, if somebody comes in, they're 75, 85 years old, and they have severe facet arthropathy, and they have low back pain, and you do a cortisone injection, it helps, but it works for 2 weeks, and they come in, this may be a good therapy for them. Because really there's a lot of deconditioning anyway, there's no joint left, it's probably better than a fusion, and if you can get away with burning something and it works for 6 months to 2 years, it's probably an okay therapy. Okay? Because you avoid corticosteroids, you avoid opiates, you avoid other things, you're making them functional, and they can work on the musculature they have. So if they have pain relief in a pain-free window, then you get them back into activity, get them into pool work, core strengthening, those types of things, they can be very effective. So the other thing is muscular spasm. It's probably a little bit overdone. We see a lot of patients that are described as myofascial pain, muscular spasm, piriformis syndrome, those types of things. And it all sounds good, but there's a lot of true pathology underlying this that is underdiagnosed or misdiagnosed. And that's the concerning thing, that we see these patients come in with localized spasm and then they do tons of therapy. Nobody is bothered getting an image. And then we see them kind of spit out of that system when they say, okay, it's been a year, I can't help you, it's not working. Why not get that person evaluated a little bit earlier? If we do scan them and yes, there's nothing there, fine, continue the therapy. If you look at the costs, an MRI probably costs nowadays anywhere between $500 and $1,000 for a lumbar spine MRI. Okay? The physical therapy sessions themselves cost patients about $250 per session. So if you're doing twice a week, every week for 6 months, and we don't know what we're treating, I think it's a very ineffective use of our resources. And so this is something that's important. But there's likely little role for paraspinal muscles in chronic pain syndromes. For these short-term muscular injuries or spasms that get better in a few weeks, for sure. But once something is lasting over 2 months and not getting better and is unrelenting, I think it's your responsibility to dig in a little bit deeper, not just put them on more medicines and continue the physical therapy. Acute axial low back pain. So if there's no significant trauma, again, the treatment of, this is kind of hard to see, so oral analgesics, NSAIDs, short-term opiates for severe pain, and muscle relaxants, lifestyle modification or activity modification, and physical therapy or physiotherapy. So that could be chiropractic care, physical therapy, acupuncture, any of those adjunctive modalities I think is important. One of the things to look at, and that's why x-rays are fairly important, especially in the right patient population, is to look for acute compression fractures. Make sure this is not something more serious. So chronic axial low back pain, usually about 40% we believe is discogenic. Lumbar facet joint pain and SI joint pain come in kind of second and third. One of the things I do believe is underrepresented, and this is old data, this is coming from the 90s, and kind of your standard allopathic pain model, I think the ligamentous and the small structures around the spine really play a large role. We've seen that in some of the regenerative medicine therapies, and I do agree with a lot of the prolotherapists on what they're doing. And they've been using prolotherapy for many years and having wonderful results with low back pain. A lot of them have switched over to the platelets. They seem to work more robustly, and I agree with that. I've seen the difference, that you have more control, and I think you get a better tissue regeneration with the platelets. But a lot of ligamentous disease is ignored in the standard pain model. Discogenic pain, we looked at that sidiovertebral nerve. So here's a normal disc. As it starts to age, it starts to lose its hydration. You get little annular tears, right? The annulus fibrosus is the outside. You start to get little annular tears and degeneration. It starts to bulge. And then you can have frank herniations where that nucleus pulsus extravasates from the disc. This degenerative pattern, it starts with a normal disc. First thing that we see that disc starts to dehydrate, so it loses its water content, loses some of its plasticity, and that allows it to start bulging, okay, or losing some of that containment. And that's where the sidiovertebral nerve feeds, so that can be painful in and of itself. So that's discogenic pain. You start to develop small fissures and tears, and if they become large enough, that's when you have a herniated disc. That's when that nucleus pulsus, that soft material, that toothpaste or jelly-like material, extravasates from the disc, and that's extremely inflammatory. It's very soft. So people think of like a herniated disc as causing a tremendous amount of mechanical compression. It really doesn't. It's pretty darn soft and pliable. But the inflammatory mediators that it releases, like PLA2 is one of the main ones, is very powerfully inflammatory and can cause a lot of pain. And so that's why medicines like anti-inflammatories, steroids, those types of things, it doesn't change the morphology of your issue, but it dramatically improves the pain. Why does that happen? It's because of this reduction in that inflammatory cascade. Then you have this thinning disc over time. These can resorb. You can have the thinning disc over time, and we'll talk about that resorption a little bit later. And then you start to have degenerative changes of the adjacent end plates. So now these discs are not doing their job, right? So now where's this forces going? It's going into the end plates of the discs, and you can start to get degenerative changes. Dr. Michael Modick from Cleveland Clinic was a radiologist who described these. They're called Modick type changes. So if you ever see in your reports, Modick 1 is edematous. So that's the first thing that we see is edema builds up in these end plates, and you can see that on the MR sequences. And those can be painful. It's like a stress fracture, stress reaction. The second type is fibrofatty change. So you start to get this higher fatty signal intensity. It's more of a chronic issue. And then finally, sclerosis, where it gets dark and hard because now the end plates have been taking this abnormal stress, and you get these osteophytes. And you can see what happens to the neuroforamen, right? I mean, that's a nice neuroforamen here and here. Here you start to see that little lipping, the osteophytosis, and the narrowing of the neuroforamen, and that becomes this chronic compression of the nerve roots. So MRI has gotten a really bad reputation for back pain because we see it, we see too much almost. It's very sensitive, and it's hard to be specific with the MRI and the clinical exam in isolation. Now, bringing them together, I think it's very helpful, and we can become much more effective. So we look at 20 to 40-year-old. If we scanned many of the folks out here today, think about that. 35% of you are going to have discogenic pathology. You may not even be having back pain. A lot of you do. Who knows if it's from the discs, but that's what we're seeing. As we get to the 50s, 60s, look at that number jump. 85 to 95%, pretty much everybody is going to have disc pathology. So that's the hard part. If somebody comes in, and this is a lot of our patient population, is over 50, they come in and they have back pain, you're going to scan them. You're guaranteed to find something, right? You're guaranteed to find something. But is that going to help you guide your therapy? Maybe not. And so that's why it takes the physical examination and really correlating where are you having this pain, what type of pain are you having. And then the last thing is looking at that inflammation. Those fluid-sensitive sequences that I spoke about before can be very helpful in determining where you have the pathology. There are patients that come in that have really bad-looking herniations on their MRIs. Their pain is axial. You look on the MRI and there's one facet joint that's inflamed and angry. You treat that facet joint, all their pain is gone. They may have had that herniation for the last 2 decades, but it's not bothering them, right? So you have to use these things wisely. Here's this, we just talked about this discussion of the morphologic changes of the disc. So this is a sagittal view of the lumbar spine. So vertebral bodies and the discs. Here's a normal disc. You can see this is a fluid sensitive sequence. So fluid is bright. So fluid in the CSF, right? Fluid in the disc. This is the first thing that we see when the discs start to degenerate is this dark signal, so dark discs. and slowly you'll see a little bit bulging. This is the anterior longitudinal ligament, and you can see here, the posterior longitudinal ligament, and you can see here the bulging of the disc, lifting of that ligament slightly. And here you see the progression where it's dark, it's a little bit smaller, and then you see the herniation. So that's kind of a progression of this process. This is a hotly debated topic in radiology, these annular tears, or what you might see called high intensity zones. So we'll see these not infrequently, and we're not sure what to do with them. Some of the older school docs believe that these are totally unimportant. They're a sign of aging, but they're not symptomatic. I'm on the fence. I don't know, because what I've noticed is these small tears, they can be painful, but a lot of times we're missing the other pathology that's actually causing the pain. It could be myofascial, it could be SI joint, it could be a facet that's angry but not overtly inflamed. This could be psychological, so it's really difficult. So you see these, we take it with a grain of salt. I'm on the fence at this point. So you'll see these little white areas, these annular tears in the outside of the disc, and it makes sense theoretically that you have those sinovertebral nerves feeding that. So if you have a small tear there, obviously there was some increased pressure, there's localized degeneration, that can be painful. So you can look at those, but they're also hard to treat. What do you do with that? Usually we've relied upon epidurals to bathe that area to see if we can reduce the pain. The facet joints are true synovial joints. We have 2 of them at each level. They have cartilage and adjacent bone, and then any process, arthritis, inflammatory arthritis, injury can cause these to be painful. And usually that's going to be a localized axial low back pain that can radiate into the buttocks or thighs. This facet joint pain is mediated by the medial branches, those branches that we saw coming off the spinal nerve. That's what's transmitting the pain to the brain. And so if we see this, we're not able to treat the joint locally, then that's one way to block the signal. But we were talking about the potential ramifications, and you can see the area that it's feeding on the multifidi and the musculature around the spine. This is a fluid-sensitive sequence, and this is what we see. And so this can be very obvious to a trained radiologist that you're looking at the lumbar spine. These are the discs looking down the barrel. These are the facets looking down the barrel. And see how bright it is here? That's all fluid. That's too much. So that's inflamed facet joint. So you can see that's 5, 4, 3. So 2, 3 facets bilaterally are really inflamed. Can we turn on the lights for just a moment? Oh, sorry, is it that difficult? I would like you to see this, though. Can you guys see that better now? Okay. If we keep them off, you're going to fall asleep? Okay. Does anybody want to keep the lights on if we're going to miss the imaging? So this is the fluid-sensitive sequence. This is the vertebral body, okay? This is the psoas musculature right here. This is the paraspinal musculature and the facet joints. And we're seeing the fluid within them. This is an en face view of them, the sagittal view, right? So we're looking at the vertebral bodies and the discs. And at this level, they kind of look like shingles. So there's a tiny bit of inflammation in this one here, 3, 4. But 2, 3 there's quite a bit of inflammation. And there's enough separation here that I would be concerned for a localized instability, okay? Because there's just too much fluid there. There's probably a segmental instability at that level that's generating a lot of this pain. And you can see here on a very fluid-sensitive sequence, this is a myelographic sequence, so it almost looks like a myelogram when you put fluid in the CSF. This is an MRI, so non-invasive, but you can see here, these are the facet joints. At the other levels, you can just see a sliver of normal physiologic fluid, and here you can see there's quite a bit of localized edema bilaterally, okay? This also works for the cervical spine. So these are sagittal views of the cervical spine. These are the pillars, lateral masses, right? You have C2, 3, 4, 5, 6, 7. And these kind of shingle-appearing structures, those are the bones, and then the joint in between, and the lateral mass joint in between. And this is one side. So we can scan from right to left. We make sagittal slices, okay? And here you see the 4 or 5 level on the left, normal left side. And you can see the joint there. There's no brightness. Here you see how much fluid there is, and there's also reactive marrow edema. So not only is the joint inflamed, it's so inflamed and so angry that the bone marrow, now adjacent to it, is edematous. Okay? And so that is extremely painful for the patient. This was read as normal. They read C5-6 disc bulging and otherwise normal examination. So it was missed. And the patient had an epidural injection, they had a surgical consultation for fusion, and nobody talked about this issue, which was their pain source. We were able to put a small 25 gauge needle under fluoroscopy into that joint, put a small amount of anesthetic and cortisone, and it took the pain away. So we had the source. This was the source. Now the interesting thing, we're kind of stuck. We go back to the other paradigm. We have steroid and we have surgery, right? Or maybe the RFA. Now throw in regenerative medicine into this mix, right? So suddenly we have a powerful tool that can actually help heal the joint if we find it early enough. So it totally flips everything on its head to say, okay, look, this is important to get these diagnoses because we actually have a therapy that might fix this or have a semi-permanent cure. You may have to come back in the future for this. And the other thing that goes right along with this is functionally trying to figure out why is this happening. Is there some muscular spasm that's putting more pressure on that? Is there some functional deficit? And that's where the world of physical therapy or chiropractic can help and come into this. But this is an important thing. This is an axial view of the same thing. This is the left side. You can see how normal and nice this joint looks from the top. And this is kind of that gnarly. You can see the spurs already, the irregularity of the joint. And this is a fluid-sensitive sequence where you can see the edema, bone marrow edema, around this facet joint. Right? So this is the vertebral body, spinal cord, right? Canal, neural foramen, vertebral artery, and then your facet. So what are the facet treatments? This is what we were talking about. So intra-articular injection, medial branch blocks, which is just putting anesthetic on the nerve to make sure it takes the pain away. That leads to a radiofrequency ablation where you can burn it. There's percutaneous fusion, or there's open fusions, and then the newer paradigm looking at stem cells and PRP injections intra-articularly in the capsule, and we've seen some nice benefit with those. This is just an example of using fluoroscopy. So we open up the facets, do an oblique view. You can see the lumbar facets here, and then placing a needle directly into that. And then we'll put a small amount of contrast, which shows an outline. Sure. I cannot. So the question was, are these patients this last facet therapy? I'm guessing that looking at this is a chronic issue. Okay. I'm not sure if that patient presented with an acute episode. So you can have acute on chronic issues where it can be quiescent for a period of time and something triggers it. Even stress. Why are they having this increased inflammation? It doesn't have to be a trauma or injury, but these can come and go. Okay. So that's a good question. With this, though, when you see these secondary signs of arthritis, it's something that's been there. This is not a new issue. This has probably been developed over several years. Okay. Sometimes they'll come in, though, and the joint will look pristine, like this one on the other side, and they'll have fluid in the joint. And that can be a case where it's just an angry, inflamed joint. And in that sense, sometimes just a cortisone injection will help. Very low dose, calm it down, the structure is okay, get them physical therapy, get them active, strengthening, what's the functional deficit, and it may go away. Okay. So you have to treat those patients individually, or maybe starting off with platelet-rich plasma, maybe even better. Here's a needle that's going into the joint, so we see this obliquely, the joint space is open. So all of these injections, everything that we do is guided by imaging, and I think that's another very important thing, that precisely place this medicine. I think a lot of the guesswork that happens in the community is a little bit frustrating because we see a lot of patients that come back with injection therapies, either from orthopedics, or they're using steroids or a PRP, and they're not using image guidance, and they're not getting better. And there's a reason for that, is that you, number one, may not have the diagnosis. Number two, even if you have the diagnosis, you're not putting it in the right place. So both of those things are crucial, and we'll show some examples on the second half of the lecture. Here's an injection into the facet joint. Okay, and then the medial branch, we talked about that. Here's an RF probe and basically burning. We know where it lives structurally, so we can place the nerve or place the needle on that area. We start off with a block, it's called a medial branch block, where we place a small amount of anesthetic where that nerve lives, and the patient goes home with a pain diary for that day. We want at least 80% reduction in their pain. It usually comes back fairly quickly. And then we may do it again based on insurance to see if it goes away again, and then we'll burn the nerve if that's effective. Again, I think it can be an effective therapy, but it's really in the right patient population. I think it's overdone right now. Excuse me. And that's quite worrisome because we're potentially harming the patient in the long run. SI joint pain can be the primary source, so sacroiliitis, infection, neoplasm trauma. So low back, buttock pain, I've noticed most time severe when sitting. Oftentimes, postpartum, several months postpartum, somebody develops, it can be acutely after, having a pregnancy, but this is something that affects a lot of folks. It presents like low back pain. One of the concerning things is when you send an MRI to any facility, pretty much anywhere in the States currently, they will do a lumbar spine. The one thing that's not included, they'll look from about T11 to S1 and sagittal and axial views. What they're not collecting information on is the SI joint. And we're going to show a couple of cases there, and that can be very frustrating. So if you have concern that there is a SI joint pathology, depending on where you are, you may have to ask specifically for SI joint imaging. So they'll do a different study. Or you can ask for additional views. They may or may not do that. Within our facility, I read everybody's MR, so we have integrated that protocol to do that, and we'll show you a case and why that is important, or cases. So it has a different innervation pattern, so it doesn't have a fixed course for the nerves, so you really can't block. It's not too dissimilar, it's just a much larger facet joint, but you can't block this joint like the other one or do a radiofrequency ablation. It has a very intricate innervation, some branches from the obturator, superior gluteal, and lumbosacral trunk as well. So the one thing that we spoke about before was this ignored sacroiliac joint. And so in the last year, we've had 5 patients, and we don't have a hugely busy practice. It's pretty busy. We have several providers, but we're, for the pain side, maybe seeing 15 to 20 patients a day, including injections and therapies. In that small volume, in the last year, with adding the SI joint sequence, 5 of these patients between 26 and 42 were scanned for low back pain. Okay, so low back pain, all comers. Some had radicular symptoms, some didn't. Every one of them had MR findings of lumbar disc disease. So what we're talking about, degenerative disc disease, right? 26 years old, from mild to severe discogenic changes. They had variable success with cortisone injections. There's a couple of patients. What triggered my interest in this is one of the patients, or a couple of them, had corticosteroid injections from me in the past for disc issues, right? They came in, they had back pain, they had leg pain. We did an epidural injection, and they had benefit. Not huge benefit, but they had some benefit. And then they came back to see me a couple of years later when I was doing this SI joint sequence. And they came in and we scanned with our new protocol where we look at the SI joint. And what I saw on these 5 patients was shocking. This is the scan through the SI joint, right? L5, S1 level SI joints. We talked about inflammation, and that is a light bulb, right? I mean, that's bigger than a light bulb. So that's a spotlight telling you where this issue is coming from. When you see this, it's a no-brainer. We got HLA-B27, it was positive. And so we had these 5 patients. So the concerning thing is that if we don't do this, and you could not see this on the regular MRI. This one we might have been able to catch something on the top, but the others, there are several others you couldn't, only if you got this sequence. So these patients would have, like I did, unknowingly, done an epidural injection. They would have had some benefit, but not complete. They'd have continued to have low back pain. We'd have tried a couple more injections potentially. They weren't getting better. I'd have sent them on, everything physical examination. They had, radicular type of pain, sent them to the neurosurgeon. The neurosurgeon would have looked at the lumbar disc, probably got an x-ray, make sure structure there wasn't anything that was too obvious. And then they would have done a fusion surgery or some type of intervention that would have been the wrong intervention. That patient would have probably still had low back pain, and they guarantee you would still have ankylosing spondylitis, right? So this is something that's important. So with Dr. Wright, we're publishing this paper. This is intra-articular sacroiliac joint injection, so the inferior margin of the SI joint. And this is the contrast, that dark fluid around there. So this would have been looking like any other of these joints. But so this is a pretty, when we do these injections, it's definitive. So part of this is for a diagnostic. So the patient comes in, they have this issue. We're still going to probably do an injection of anti-inflammatory and anesthetic to see if this is helpful. When we did this for this patient group, complete resolution with the anesthetic phase. Some of them had tremendous relief with the cortisone. We were able to get them to, rheumatology. We were able to get them to other practitioners, some of which are controlling their ankylosing spondylitis through naturopathic means, through natural means, anti-inflammatory diets, other things. And some of them had to be put on Enbrel, but they're still doing well. But at least we know the diagnosis, right? Another case, they're talking about just kind of the imaging around getting to the right diagnosis. 46-year-old female, acute onset of left hip, buttock pain, completely normal MRI. And this was really subtle, but the main thing that triggered this was the physical examination. This was her MRI, completely normal. And we did the sequences through the SI joint. And so the other one was really obvious, right? Kind of frying pan hit you on the head. This one is very subtle. She had left-sided SI joint pain, and the only difference you can see from side to side, this is the SI joint here, there's just a touch of high signal right on the anterior border. It starts to become a little bit more apparent. This is on top of, deep to the iliacus musculature. You can see a little bit of edema here, here, kind of where the ligaments live. All right, and so that's the subtlety, but all her symptoms were SI joint related. And so we did an SI joint injection. At the time, I was kind of going back and forth between using CT and X-ray. I only use X-ray now. But here's the needle placed into the joint, and you can see that's the contrast injected into the joint. So definitive treatment, and they had complete resolution of their pain for some time. Okay. Radicular pain, so pain radiating down the legs, low back. So that's mediated by the proximal spinal nerves, and there's two general processes, compression and inflammation. And so this compressive radiculopathy, this sciatica term that you always hear. So what happens? There's pressure on these nerves, right? Pressure and inflammation. So the compressive part is that you have pressure, results in local ischemia, right? You have the vasovasorum and vasonervorum, and so basically those arteries are getting altered, and you have this altered axoplasmic transport in the nerve, so it starts to become painful. You have loss of inhibition of the pain impulses carried by the unmyelinated C fibers. And so what can cause this? And then you have your differential diagnosis, a bulging disc, the stenosis, maybe from bony changes, spondylolisthesis, neoplasm infection, fracture, or piriformis syndrome, which is extremely rare, by the way. So here's an example of a herniated disc. The nerve is coming down there. You can see it's kind of deflected. Here you see more pressure on that nerve, and this is an axial view. So L5-S1. This is S1 in the lateral recess. So going down here, you can see it's compressed or compromised. Here's another example of that compression. So this one, we talk about lateral recess. So remember, that's the canal, right? And this is the lateral recess. This is where it's heading south. So S1 is passing the L5-S1 level. This is foraminal. So this is where the nerve roots are actually exiting, okay? And that's where we talk about the facet joints, the lateral discs, and these osteophytes compromising. Remember that pork chop view that I talked about? These are the happy nerve roots, right? And this is a sad nerve root. So really getting compromised. And so this could be a source of radicular type symptomatology. And then the inflammatory component, which is what we are able to treat with the cortisone injections, basically from chemical irritation. I tell my patients it's the evil humor is being spewed forth and pissing off the nerves, and that's why you're having the pain, and we're going to try to calm that down and try to make it simple for them. But basically, it's this injured disc, herniated nucleus pulposus, and it's phospholipase A2 that's causing this inflammatory cascade. And then we can use the dermatomal patterns. This is not exact science, but it can be very helpful where they're having the pain. Right? If it's more groin, it could be L3, thigh, anterior thigh, L4, lateral thigh, lateral leg, L5, down to the dorsum of the foot, big toe, L5, S1, down the back. So most commonly L5 and S1 related issues. And so here's a transforaminal epidural. We saw where the nerve roots are coming out. And here's a needle, and there's the dye traversing that. And you can see that it does travel up and down a few levels on the lateral where you can see the epidural space. Here was one where the contrast was a little bit more clearly seen. This is L5 S1 level. So L5 nerve root traversing down, and those are the epidurals, the needles, and you can see actually the nerve root surrounded by the contrast. This was a patient that had spondylolisthesis L5 S1, severe low back and leg pain, had tremendous relief with the injections. And so we use them for diagnostic and potentially therapeutic purposes. The diagnostic, the anesthetic inhibits sodium transfer and prevents transmission of pain impulses. And so it selectively affects some of the fibers that mediate pain and temperature earlier than they do with the fibers that are, the alpha fibers that are carrying the postural touch and motor information. So you won't always get profound motor weakness or other issues with these injections. If you use the right amount, they can have a very effective immediate relief. And that helps diagnose the pain generator. I call it the proof in the pudding, right? You do the injection, you put it in that area. If it helps, you're in the right spot. If it doesn't, you may be barking up the wrong tree. And then the longer term, the therapeutic effects, the anti-inflammatory and immunosuppressive effects of the steroid, not completely understood, but it does help block that inflammatory cascade. And here's a nice slide talking about that. So we have disc injury, tissue injury, nerve injury, creation of these neuropeptides and cytokines, phospholipase A2, and the steroid affects it at this level. So this blocks it at a higher level than these anti-inflammatories like NSAIDs, which are working on the cyclooxygenase pathways. So you get a more effective response with the steroid, a little bit more powerful. And we're putting it locally as well. One of the other things that we've been using lately is a blood pressure medication called clonidine. It has some powerful anti-inflammatory effects as well, very safe. It causes everybody to drop their blood pressure significantly, though, and that's the concern. So we have patients waiting 3 hours sometimes after an injection, so it's not the ideal logistical injection. They use it quite a bit in Europe, but it can be very effective. Patients that have had too much steroid are really sensitive to it, or you're worried about their other issues with it, it can be helpful. And we're trying to look more into using that as well as ozone for epidural injections. Side effects, short-term insomnia, facial redness, mood swings. If they're hypertensive, diabetic, it can affect that. And then these other ones, usually, and I've never seen this with epidural steroids. One of the things to consider and be very careful with, patients that come in that have had steroids before or you're considering putting them on oral prednisone pack, please be careful and judicious with your use. I've seen too many 35-year-olds with AVN that have received 6 or 7 Medrol dose packs in the 2 to 3 years preceding their event. So be very careful. The epidural injections are much better if that's the issue that you're dealing with. Selective nerve root block, we talked about that. And so the nerve root blocks are on the side here. This is the lamina of the vertebral bodies, and interlaminar injections are ones that are placed centrally. These are more for multi-level disease, and you can see the contrast here. It's flowing up multiple levels. Voice is failing me. All right, and this is a caudal epidural. So sometimes they can do this in the clinic. There's a sacral hiatus, basically a hole in the sacrum that connects with the sacral roots, and you can access that. This can be done in the clinic. It has been done for years or decades. I think this is a more effective, obviously, with imaging, and you can see the contrast affecting the sacral nerve roots. And this can be very helpful with coccydynia, with pelvic floor pain, other things like that for those types of injections. So just the tissues that are affected more caudally. Central spinal stenosis, basically from disc disease, facet arthropathy, other issues, will cause narrowing of the central canal. One of the ways that you're going to see this present is what we call neurogenic claudication. And the patient will present with severe low back pain and leg pain, and usually this is precipitated with prolonged walking. And it can be a certain distance. I walk 2 blocks and suddenly my legs are killing me. I feel like I'm losing strength. I have severe pain. I have low back pain that increases. One of the things to ask the patient, so we've encountered this 3 or 4 times this past year, talk to the patient about when the pain stops and how it stops. So just if you can remember this will be very helpful for you for your patients, because these patients have come to us through primary care, so it was missed. Ask them, when the pain stops, are you just standing and stopping and does the pain go away? So basically what that means is they're stopping the oxygen demand requirements for their musculature and staying in the same position. Once that demand diminishes, their pain goes away. All right? So what is that telling you? That's telling you that there's not enough vascular supply to those muscles. All right? Vascular claudication. If they come in and say, I walked a certain distance, back leg killing me, what do you do to stop it? I sit on the nearest bench. I lean over the grocery cart, right? Those types of things. What are they doing? They're changing the position of their spine. Those nerves that are compromised, the vessels that are compromised in the central canal are now being alleviated. The pain goes away. Then obviously what's the next thing to do? Check all their pulses. Check their femoral pulses, check the DP, do those things. Make sure that they don't have vascular issues. And the few patients that we've seen, 0 femoral pulse on a couple of them, no DP. They've had iliac issues and more proximal issues that were causing, and then we send them to the vascular surgeon or interventional radiology. So that's one of the things. And so this neurogenic claudication, if it becomes bad enough, then we can get cauda equina syndrome, where the nerve's very rare. So you could think about it, but very rarely are you ever going to see this. But profound paresthesia, numbness, saddle anesthesia, loss of bowel bladder. Right? That's a surgical emergency. They need to go to the ER. They need to go see a neurosurgeon. This is the central stenosis that we talked about. We saw where the pork chop view, right, on the outside where the nerves are going out. This is down the central canal, the barrel, and that can be caused by disc issues, by facet, ligamentum flavum. That's this dark band here. That's a ligament that's hypertrophied, right, and this disc herniation, hypertrophied facet joints. Everything is compromising this central canal. Right, these are happy nerve roots floating. This is an axial view. So the little dots here are the nerve roots, and you can see that bright is the CSF. This is the same patient, 3-4, you can see that they have no CSF signal, right? So severe central canal stenosis. Surprisingly, this happens over a long period of time, right? This is not usually an acute issue, and we have something, thank God, called neuroplasticity. And so oftentimes these patients can have minimal symptomatology, and if you can control them with injection therapy or simply physical therapy and modification, you may never have to do anything for this. Here's a cervical spine injection. Here's a needle, and that's the epidural space, that thin fatty layer outside the spine. You can see here they had severe central stenosis and pain, and this was very effective. This was under CT, just to show you kind of in 3 dimensions where that needle is going. And so this is a little bit of a sphincter tightener when you do these types of injections, right? Because there's the spinal cord right deep to it, and this is about a millimeter space or so that you got to get into. So the technique is, it's pretty elegant, use loss of resistance. So it's not just image guided, there's feel to it as well, but those can be very effective therapies. And then referred pain, we're talking about other issues, aortic aneurysms, pelvic disease, renal disease, tumors, gastrointestinal issues. So something to make sure that you discuss as well. Don't lump everything into musculoskeletal issues. So when do you order the MRI? Failure of conservative measures after 6 weeks, so unrelenting, non-improving pain. Red flags to get them earlier and maybe get a neurosurgical consult or consult with someone like us is progressive weakness in the limbs, loss of DTRs, this saddle anesthesia, a change in bowel or bladder function, or severe recalcitrant pain. You're doing everything, and they're just totally affecting their lives. They're not able to improve. Let's find out what's going on. So the conservative therapies that we spoke about prior to intervention, 4 to 6 weeks, topical NSAIDs, short-term opiates, muscle relaxants, neuroleptic medicines, gabapentin, Lyrica, especially for radicular symptoms, can be effective. PT, DC, acupuncture, lifestyle change, activity modification, and that's what we use a lot now, more and more with our naturopathic resident and Jeff. We're doing anti-inflammatory diets, changing the way that they're feeding themselves. Nutrition is such an important part of this. And worst case scenario, they're getting a lesson in healthier lifestyle, even if it's not directly affecting their acute episode. It's going to help them in the future. And the other thing is just sometimes it's just a tincture of time to allow them to heal. So we're going to go through that. Okay, real quick, how are we doing on time? Oh, 35 minutes? Okay. I'm going to go through this. We already talked about MRI. Use a good one, okay? You got this, even though this was the sports series Hugo, this McLaren's probably a little bit better. Your patients are going to pay the exact same for an MRI. MRI is billed as MRI is billed as MRI. Use the good ones, okay? You're going to get a lot more information from a 3 Tesla, okay? So I don't own one, all right, but I use them. When I use them, I like to use a 3T. Better signal-noise ratio, right, higher resolution, contrast. They're faster. The patient spends less time in there. And overall, they're much better. Specific uses, if they have a hip replacement or joint replacement or artifact, then you may want to use lower field strength. And again, this inflammation and edema is important. If they're claustrophobic, these are the new scanners. You can see how much room there is in this one. This used to be the old ones, all right, and this is an open. So it's much less claustrophobic. This is an upright scanner. There is one in Seattle now. There used to be, Epic used to have one. It was okay. It was just very cumbersome to use. And just one example of, this is a patient, 67-year-old female, chronic right hip pain, low back pain, buttock pain, evaluated by lumbar MRI, and they thought it was her facets because they were inflamed. She came to us for second opinion. It was the clinical examination, had severe hip issues as well. This was the lumbar spine, had a little bit of a herniated disc, and had facet effusions. We talked about that. The other thing she had, though, when we examined her, we said her hip seems to be where this is coming from. We scanned her hip. Again, fluid is bad in musculoskeletal. This is the gluteus medius insertion of the greater trochanter. Look how bright that is here. It's a partial tear, severe bursitis. The other thing that was going on, this is a sagittal view of her hip joint, because she had intra-articular hip type pain. She has full thickness cartilage loss. All of this here, that bright, it should be gray. Those are the two opposing cartilage surfaces. Large cartilage defect. So she had, arthritis of the hip and a severe tendonitis bursitis. That was really the pain drivers. We did injections for her with cortisone as diagnostic. All her pain went away. Nothing was coming from the back in this case. And we followed those with PRP. This is another case I thought was interesting. Marathon runner, young lady, very physically fit, was having severe right-sided buttock hip pain. Had gone to even to the level of the neurosurgeon. They were ready to do surgery. She came in, and we spoke a little bit, and we talked. I did a scan of her hip. Again, I wasn't sure exactly where this was coming from. Very subtly, the origin of the iliotibial band right here was edematous, and it was thickened, barely seen on the MRI. And it was only because I was pushing on her and I was looking at the imaging at the same time did we figure this out. But this is the origin of the IT band on the asymptomatic left side. This thin band of tissue right here, and then attaching to the bone. And that's the top of it, superficial surface here. That's the bottom of it here. This is the one on the opposite side. Much thicker, much more inflamed. And you can see how large and hypertrophied it was. There's actually a little calcium deposit there. That was the source of her pain. We did an injection into that tissue. She was able to run the marathon that weekend. And so that's another reason to really look at the patient, push on them, find out where it's coming from, and don't lump everything into a single group. Why don't we take a 5-minute break? Sorry, I kept talking. I told you. 5-minute break, and then I want to show you some of the regenerative medicine pictures, and then a little bit of that. All right. So I got about half an hour, and we'll have people trickle in. But this is kind of this is my passion. That other stuff is really cool, but I've really gotten into the regenerative sports medicine, injections and therapies, and that's kind of what really drives me at this point, kind of learning more about these. This is another lecture of mine, and just talk about today's pain management challenges. Increased musculoskeletal care, baby boomers, recreational athletes. We talked about, Northwest, and the hiking, the skiing, the running, all the other things, kayaking. That we'll see a lot of these injuries. We're limited, and the government and society is pushing us to limit narcotic use, which is a good thing because we can get to the diagnosis. Some of the bad things: limitation of physiotherapy visits. They're not covering. A lot of the coverages don't have alternative and adjunctive care. They don't have any coverage for regenerative medicine injections, so PRP, stem cells, but they will pay for steroid injections. And some of the insurers now, which is truly frustrating, is when I have a patient coming in with chronic arthritis that's not super inflamed, they're having this chronic pain, they don't have a ton of fluid or an infusion, they're making me do a cortisone injection to prove that that's the source of the pain before doing hyaluronic acid. I'm a pretty big believer in hyaluronic acid. It's paid for by the insurance. For mild to moderate arthritis, it works very well. And they're kind of controlling the way that we practice, which is extremely frustrating. Here's my conspiracy theory. So big businesses driving government and medicine, obviously. Ortho and spine make their money with implants and surgeries. And the regenerative medicine may cause them to lose revenue. So there's a huge pushback. The FDA wants to control use of even centrifuges in the office. So they would make using a centrifuge illegal. A physician cannot use a centrifuge. So that would effectively kill all of our regenerative medicine therapies. Steroid injections make patients feel better. They make the tissues and joints worse over time if overdone. And it's not uncommon that I have patients coming in from clinics that have had 7 to 10 cortisone injections in their plantar fascia, 6, 7 injections into their knees or hips with cortisone. And basically what's happening is they're accelerating that degenerative process, and the patients feel wonderful, they trust their physicians, and they're getting these scopes soon after because now the cortisone has limited use, diminishing returns. They have more pain and then they get a scope. And obviously the newer literature has shown that meniscectomies for non-mechanical meniscal tears actually accelerates the progression of arthritis. It's not beneficial. So going in there and cleaning up stuff is really not the best thing to do unless there's a huge displaced fragment. So, and then what does that lead to? The meniscectomy leads to further acceleration of your arthritis, and then you get your knee replacement. So it's really a pretty terrible downward spiral. And so when you guys have seen this, normal wound healing, inflammation, proliferation, and remodeling. You remember that slide. And regenerative medicine, so a new paradigm. And we're going to kind of go through this because we don't have too much time. I want to show you the cases. But regenerative medicine covers the worlds of the stem cell, cellular therapy, the injection therapies, and then this tissue engineering as well. And so this is from Wake Forest University, where they're using bioscaffolds and 3D printers to create tissues, implanting them with cellular material, and then regrowing artificial limbs, ears, kidneys, organs. This is pretty amazing stuff they're doing down there. And what we're going to focus on is the injectable therapies, basically harvesting stem cells, growth factors from your body, and then injecting them into tissues. One of the big things that I've seen that has made this much more effective is the diagnostics. So using the MRIs, like we spoke of, to find these small partial tears, areas of inflammation, capsular injury. You saw that partial tear of the origin of the IT band, that's the pain generator. That is the perfect case for platelet-rich plasma because it's a soft tissue, it has some vascularity, it's an enthesis, a bony attachment. Injecting that area with PRP and providing some physical therapy, that thing's going to heal, right? I mean, that's a perfect case. So the two things that will help that, number one, the diagnostics, because we figured out where it was coming from. Number two is placing that medicine precisely, and that's where the ultrasound comes in. So it's the lock and key. And we have the two things that go hand in hand together that make this a truly effective therapy. We see a lot of PRP that's done in the community that's done blindly, and the patients come back and they have failures. So it hurt worse. My pain was down here. They injected my deltoid. Well, likely it was a bursitis or a partial thickness tear, the rotator cuff, and they treated the wrong area. And it's not pixie dust where you can just kind of throw it in regions and allow it to heal. So this is a picture of the ultrasound, transducer, bursa, underneath their chromium, and here's the syringe. So you can see, has anybody here seen ultrasound injections, ultrasound guidance? Let me see a show of hands. Okay, so a few of you. It's very elegant, it's very obvious. I always say it's kind of like a Mack truck coming down the highway, and you can see where you're going. This is a bursa. This is probably, somewhere in this line of an 18 gauge. It's actually going into the tendon, so this is probably an aggressive PRP type therapy. The bursa is here. This is probably a millimeter or two thick, and so it's very precise. My personal paradigm shift, so I started doing all of this, seeing the patients, using a lot of cortisone, and the thing that changed me, I started to use PRP about 5.5, 6 years ago, and we were using it for failure cases, patients that had no benefit with the steroid, soft tissue injury. I wasn't happy at all with what I was getting with partial thickness tears of tendons, and that's where we started with. And this was one case that came in, a 43-year-old school teacher that had a 70% partial thickness tear of her Achilles tendon. So that, again, this is high-level 3 Tesla MRI. This is the Achilles tendon here. It should look more like this all the way through its attachment. This is a tear within the watershed zone, about 4 centimeters proximal to the insertion, and that's where we usually get the injuries. The white area is the tear. The dark area is some connecting tissue. So they had about a 70% tear. You can see retracted fibers right there, and this is an ultrasound view of that. That's a part of the tear there. Here's the needle going into that and injecting the PRP. This was over the course of 4 months, so 2 PRP injections. They were in a boot for a week, and then back to activity. And you can see here's the tear in the sagittal view. Here's in the axial view. So this is looking down the barrel. That's part of the residual tendon, and that's the tear. So we had about a 70% thickness tear. This was 2 injections over 4 months. They came back. That tear was completely healed and completely asymptomatic. They actually went on to have their other one treated that was just tendinopathic. It didn't have a tear, but it was starting to hurt them a little bit. So she was a school teacher, was able to get completely healed before school started again. That was her agenda. And so when I saw that, I ran around the imaging center. When I saw this image here, I ran around and showed all the other radiologists, and I was so excited. And I said, this is called the American Buddhist. That was me. So a little bit excited. So the PRP preparation, basically, take whole blood from the patient, anywhere between 30 and 180 cc's. Right now, we're using FDA-approved kits. They've been more accurate for us and more stable. So we're getting some variable platelet counts doing it ourselves right now, so we haven't perfected that technique. And it can be spendy. I want to make sure that the patients are getting what they're paying for. We're able to extract the platelet-rich layer, the buffy coat.
and inject it back into areas. So pretty simple process. It affects wound healing. So basically, when we talk about an injury, and a chronic injury like a tendon injury, it gets stuck in this chronic inflammatory state. It just can't get to the proliferative and remodeling phases. So what we do is we're able to affect a change at this level by re-energizing that tissue. You're putting in all these growth and healing factors into that tissue and allowing it to progress. A thing that goes hand in hand with that, and I've spoken about this multiple times, is the physiotherapy or physical therapy. And especially with tendons, if you have a hole in that tendon, you're putting all this tissue or this regenerative capacity in the tendon, you need stress on that. Just like when folks work out, you're tearing your muscle so it gets stronger. You need that stress on the tissues. You need the expression of that force in that vector, and then the tissues will start to align. You'll get that nice type 1 collagen to rebuild, and so that's really important. Without that, people may get better, but I've seen it be much less effective. Patients that say, I've had physical therapy, I'm not going to do that again. And I used to kind of fall for that line, but I'm pretty rigorous at this point. We use it for joints, tendons, ligaments, muscle tears. So when we started doing this, the main thing was, is it safe? We talked about that in the beginning. What's the safety profile? It's been used for over 30 years in orthodontia and in equestrian, or in veterinary medicine. They're much more advanced than us. They've been using stem cells, seeing very good results, and there's no placebo effect. That horse is going to run or it's not going to run. It's going to be hurt or fixed. And so the PRP to me was the gateway drug. So I like this. I like cartoons. So I like this cartoon. So this is basically the kind of entry level, I thought, too, and maybe prolotherapy precedes this, but the entry level to these things, this regenerative medicine realm. So now what we've been doing more and more of are the stem cells, and I'll kind of explain the difference, but these are unspecialized replicable cells that live in our body in various tissues. You have small amounts in your bloodstream, you have it in your more proliferative amounts, or more prolific amounts in your bone marrow and in your fat. And in the fat especially, it stays pretty stable levels throughout life. There are pericytes in the fat that can convert into stem cells, and so those can be very effective. As we age, somewhere around 35 and older, unfortunately, our bone marrow supply starts to diminish quite dramatically. And then when we hit 60s and 70s, there's pretty small amounts. Now, the bone marrow can be very effective. It has tons of platelets, probably 10 times the amount that you get in your bloodstream, concentration-wise. So it can be an effective PRP. But as you get older, it may not be the best thing for the stem cells. And so we're using, autologous human mesenchymal stem cells from the patient. So where do we use the different ones? For PRP, I consider it like if you have a broken wall, the bricks are all together, the wall's kind of falling apart, and you need the spackle or the things to put it together again. That's what the PRP is. It's that growth factor, right? If you need something more robust, if the tissue's more degenerative, if the tear is larger, if it's a labral tear or a meniscal tear or something that needs a more robust response and you need a cellular material there, then I've noticed that the bone marrow or fat-derived stem cells seem to work a lot better. The other thing that we have used in the past, and use it sparingly at this point, is amniotic membrane. So the amnion and chorion. This has been used, FDA approved, for trigium, a condition of the eye. They use little flaps of this, and also wound healing. It's FDA approved. What they have done for sports medicine is they've taken this amnion and chorion and broken it down into small particles, particulate matter, and you can reconstitute it with saline and inject it just like a PRP. It's chock full of growth factors, metalloprotease inhibitors, and things that help with reduction in inflammation and healing. The other nice thing is that it's non-immunogenic. There's no HLA antigens on the chorion and the amnion, so we don't have that host response to that. It does cause a more robust inflammatory response. Patients complain of it hurting more. And so what I'm going to go into now is some case studies, really focusing on ligaments and tendon injury because they're easy to image. This is the concept that I want you to think about as far as ligament and tendon injury. This is your natural tendon or ligament, right? And this is when it starts to break down and become tendinopathic. So you lose that structure, you get those frayed edges, you get those, and if it's acutely inflamed, you can get inflammatory mediators in the area. This was one study that I thought was very powerful, and it has gotten very little press. They did an abstract, and for some reason they didn't publish it. But I thought it was a very simple and interesting study. There was 204 patients. These are orthopedic surgeons. 204 patients, 50-50 split with partial thickness rotator cuff tears, MR diagnosed. And they did simple intrabursal injections. They didn't go and try to perforate or do a tenotomy with the tissues. They just did a bursal injection. Half the group, 102 patients, with steroid, half with PRP. This won best poster at AOS 2013. So 3 months later after the injections, the PRP was statistically better than the cortisone injections. Patients were doing better. This was profound, though. 1 year after the injections, 3 patients in the PRP cohort had undergone surgery for recalcitrant pain. 3. Less than 3%. 48 in the corticosteroid group had gone to surgery for recalcitrant pain. So you can see the difference. Think about that. You saved 45 surgeries in 204 patients. Right? That's amazing to see that. So this is a huge implication on the cost to society. You think about all these surgeries that are done. And the studies are coming out every day showing that we can't afford it. Our country simply can't afford that. The other thing is the systemic effects, and we're seeing this too, also with the stem cell therapies. This is Amy Wasserlane out of Stanford. She showed that with localized injections of PRP, this was an activating source for biologic pathways. It was so much so that some of these IGF-1, VEGF, beta FGF were elevated in the bloodstream that would trigger positive results on the WADA testing. Okay, so it's interesting that a local injection is going to create or stimulate synthetic pathways, and so that's what we're seeing, and even more so with the stem cells. And they've shown some of those similar studies with stem cells for cardiac disease, where a year or 2 years later they're seeing increased stem cell load in the peripheral bloodstream, and so other areas of injury are healing better. This was a case of calcific tendonitis, 42-year-old drummer, and he had 6 months of shoulder pain, recalcitrant to physiotherapy. He came in, he had this large calcium deposit. This is this black thing here, and it's surrounded by fluid and edema. This is a sagittal view of the shoulder. So humeral head, right, glenoid, acromion, and the rotator cuff coming through here. So you have this big calcium deposit, but the rotator cuff, this should also be nice and dark. You can see these lines here, the white lines. That's fluid imbibing into the structure of the tendon and demonstrating that it's injured. It's kind of just I call this like a gamush, and it's not very healthy, right? You can see this. This was after 2 washes. We do a calcific tendonitis lavage aspiration, and so we washed as much of the calcium out as we could, but the tendon was still not very healthy. The patient had about 30% reduction in pain. That kind of the inflammation pain had gone away, but the chronic tendinopathy hadn't. And then we did the amniotic membrane injections with ultrasound, and you can see over the course of a few months, this irritated, angry-looking tendon, like that other rope, had suddenly started to reform, and here you can see this really nice, normal-looking tendon. Okay? And that's the body's ability to heal. This is a little larger example of that. You can see this picture where it's irregular, partial thickness tears, and here, that same area, very confluent, very organized. So think of that rope example. All right? Another one, partial thickness tear patellar tendon. So a lot of these younger patients, this was several months old, they had a basketball injury, and we're looking down the barrel of the patellar tendon. You can see this bright area. So a little partial thickness tear. It should look like this, dark all the way down. So number one is finding the problem. Not everything as they come in with knee pain is arthritis, right? So these soft tissue injuries are very prominent. Here is the tear. This is the ultrasound of that same area. This is the inferior patella. This is the tendon. And see these fibers right here? That's that type 1 collagen. We call that a fibrillar pattern on ultrasound. So very taut, well-organized type 1 collagen. And you can see here you lose that, right? It becomes irregular. It was interesting. We put this 25-gauge needle into this area, injected the PRP, and you can see that it's well demarcated where the PRP is going, right? You have this soft tendon. It's kind of not a very healthy tissue, and you inject this, and it fills this healthier tissue where there's type 1 fibers. It's not accepting that. So we injected that area. This was 5 weeks after, and you can see this start to fill in right in that area. You have about 95% reduction in pain, and you can see it's almost normal right in here. The other thing that's interesting is that effusion that the patient had, they had a little bit of joint fluid, that's also resolved. So it's having some localized regional effects. This is a patient, he was an employee of the city, forest ranger from Multnomah County, and they were cutting down some trees. He had an acute injury and had this partial thickness tear of the common extensor tendon. So you can see this a ton, right? Tennis elbow, or this was a little bit more severe. He had a partial thickness tear. And they gave him a cortisone injection in the clinic. without guidance. He didn't have any benefit. Came to see us. They had done the MRI. He was on leave because he couldn't work. He had severe pain. I asked them to do PRP. They wouldn't pay for it, so we did a cortisone injection with guidance. And he felt quite a bit better. He came back 4 months later, and he had worse pain than he started off with. Not an uncommon story with cortisone. The tear looked similar, if not slightly larger. And so we told him about this, and we had the amniotic membrane at that time, so I did it for free for him. But we did this injection, and you can see the tear here on ultrasound, here, that triangular structure, and you can see the dark area right there. So this is like 1.5 millimeter, 2 millimeter tear. It was a very small tear, so you have to be very specific about where you're going. This is the needle, and we placed the injectate right into that area. He came back 6 weeks later, had about 80% pain relief, had plateaued, getting better, and we had all of this edema, and it actually looked worse because it's brighter. It looks like it's thicker, so I was worried. I said, "Are you really having pain relief?" And he said, "No, it feels great, but I have, I'm just not there yet. I'm working, but it's still giving me a little pain at night and some other issues." And so what I realized later on was that even though it looked worse, it was much more edematous, the conspicuity of this tear had greatly diminished. So it's just less obvious. And what was happening, this is that proliferative phase. It may have taken him longer, but he's still in that building phase. There's all that cellular material in that area. And then a year later, he came back. This was after the second one. And you can see it's completely normal. And so that was so I went through every slice because people said, "Is that the right slice?" I just want to show. So looking at here, this is the this is the post with steroid where it's actually maybe elongating with the tear, and here is the post. And if we see him back, if he keeps up his exercises and things, this is probably even going to look more organized and better later. This was a 46-year-old decathlete, jumper's knee. This was an 18-month-old injury. So these are chronic injuries that are coming to us. They had a little avulsion of his patellar tendon origin. This is a piece of bone right here. This is edema surrounding that. He could not walk upstairs. He was heading right after he saw me to the psychologist or psychiatrist's office to start antidepressants because he's so depressed. This guy was number 2 in the country in senior level, extremely fit, extremely active, could not walk upstairs without pain, and was really seeking some help. He had seen a couple of orthopedic surgeons that were ready to do surgery, had one cortisone injection without benefit. Here's that little piece of avulsed bone, and there's the tear. Here's the area. So here's the kind of the correlate. This is the patient lying flat. There's the patella, right? There's the tendon. And you can see the nice organized tendon fibers right here that demarcates the superficial margin of the tendon, inferior border. And all of this is just irregular tissue. This is the avulsed piece of bone that's shadowing that came off of here. So this is the needle placing that PRP. It took me almost a year to get him completely better, and it was a progression through that time. So we gave him our first injection 6 weeks later, no pain with stairs. Started running him, had pain. Brought him back, did another PRP. He could run, jog without pain. Sprinting, he had pain. Injected him again, he could sprint, and then finally it was ballistic. So it took us a long time, a lot of rehab, but he was making zero gain prior to that with any other regimen. And this is the before and after, and he won the national championships the following year. So it took me a year to get better, and then in 2012 he won the title again. So he did extremely well for that and was very pleased. This was a 2-year-old injury, 37-year-old female, again similar, patellar tendon origin, dashboard injury. This is a good case. This patient had open scan MR, and they said normal knee. They didn't pick up this area of edema or injury, this split tear. She had hit the dashboard right there. They said nothing's wrong with your knee. She was on disability on narcotics at this time. And so she came in to see us, was really frustrated. We did a 3 Tesla MR, found this, and it fit with her physical examination finding as well. 1 PRP, 6 weeks later she came back. Complete resolution of her tear and all of the edema around it. You can see all of the inflammation. The bright here is bad. Here is the normal tendon. It looks like this one here. You can see that's fixed. That linear tear is gone, and she had complete resolution. She came back 6 months later, had lost 35 pounds, brought us a bunch of presents, and was extremely happy. This was a flight attendant, common extensor tendon. She was on disability as well. I forget how old this injury was, but she could not work at all. Severe partial thickness tear of the common extensor tendon. So this is the radial head, lateral epicondyle at the elbow, right? And all of that, there should be nice dark tendon filling in all of this. It was bright. And then you can see this huge joint effusion. So she probably had some radiocollateral ligament issue as well and instability. And you can see how inflamed and angry this was. Is there a question?
Do you
I do not. They may have it in that article, but I'm not sure how far out they followed it. But I can give you that particular article if you need. We have that on file. The question was how long VEGF and beta-FGF were elevated after PRP injections. Again, this was patients 6 weeks later, 1 injection, and you can see the resolution of this tear. She had new neotendon created there, and here's the axial view here. All of the edema, the instability, all those issues had gone away. And so that was 1 treatment, some physical therapy, and now we're treating her knee 3 or 4 years later for an injury, and this is still resolved. So this was a curative therapy. Full thickness rotator cuff tear. This is actually one of our employees' husbands. A laborer, works in a warehouse, pretty active gentleman, very fit, and had a full thickness rotator cuff tear. He came to me with this, and I said, you got to go to the surgeon. I don't think this is going to work. He refused. So we tried the PRP. This was the ultrasound of the tendon, full thickness tear right here. This is what a normal tendon should look like. This is the humeral head, right? Greater tuberosity, normal tendon, the thin bursa overlying it, deltoid and fat. So you can see that here, there's a large defect. We call this a sagging bursal sign. So you can see that there's nothing here to hold up the bursa. Here it's convex, here it's concave. Here's the needle, putting the PRP into that area. This is ultrasound follow-up 5 months later and 1 year later of this defect. This is the proliferative phase and healing, and then this is finally actually neotendon coming. It's not perfect looking, but he had no pain, so we weren't going to go back in there. This is a 1 year follow-up, 2 PRPs later. You can see there's the full thickness tear. This is kind of that proliferative phase with some material developing in there. He had dramatic reduction of pain, but it didn't look that much better. And then this was a year later. We actually had neotendon attaching, and this is several years out as well. A sports hernia, kind of a misnomer, but adductor rectus abdominis aponeurotic plate injury, core muscle injury. Very common in soccer players, young athletes, football players, cutting athletes, and they have severe groin pain. Not everything is a labral tear, so be careful. So if it's groin pain, physical examination, resisted adduction is very painful. When they start running or cutting, they'll have pain, and if they take a break, the pain seems to go away. But whenever they reinitiate athletics, it'll start again. But you see here, this is the tendon attachment to the pubic symphysis, and there's a partial thickness tendon tear. There's also this stripping of the periosteum. And PRP is not generally recognized as a therapy for this. We do cortisone injections for these soccer players, and the surgery that they have for this is awful. We see patients come back, and when it doesn't work, it's a disaster. It's truly not the very effective surgery. There's a few centers around the country that are purporting this. We've sent patients out to that, and they just haven't had good results. We've started doing PRP, and almost every single patient that we've treated has gotten better. I think everyone that we've treated that had this particular process has with PRP, and it's ultrasound guided. You put it in the right spot, and they seem to do very well. But here's the tear. Again, bright is bad. Tear is right there. That's where the adductors come in, and here you can see the rectus insertion at the front of the pubic symphysis. Here's that stripping of the periosteum, which can be very painful. This is 2 PRPs later. Patient could do no athletic activities before, is now skiing, soccer, everything like that. You can see the tendon is healing in, and that periosteal stripping is completely gone. And this is another last one, and we're out of time, but this is exciting. I have another case that's not on here, but this is a herniated disc. And this was the herniated disc initially. This patient came in, and there it's pressing on the nerve root. The nerve root's here, getting squashed, right and left. This is S1, and this is S1 here. They came in knowing that they wanted epidural PRP. I was a little bit apprehensive. This was a couple years ago. I hadn't done that before. He had not had any injections. He had a couple of cortisone injections. He had no benefit. And he told me, you promised me you'd do this. So I talked to several colleagues, and we do epidural blood patches all the time. And so we said, okay, we'll do this. I did the injection, PRP, and this was a standard PRP with RBCs, and it's somewhat semi-inflammatory. And he called back 7 days later, complete resolution of his sciatic pain. He had some low back pain that was persistent. And we went back, and I told him, come in, I want to scan you again. We scanned him again, and you could see that the disc was about half the size. We did a couple more treatments. That's the disc, here's the nerve. And he had complete resolution, and this was permanent. He didn't have a re-exacerbation of his sciatic symptoms. He continued to have some low back pain, but it was pretty profound. And we've been treating more and more patients with epidural PRP, and now we're going into the realm of intradiscal stem cells, bone marrow, and fat, and we're seeing some pretty amazing results. We've just started to re-image. We have a couple of cases, but that's it. Thank you very much.